And we're going to move on next to another video presentation. This is from Dr. Lee Herrington with the slightly ominous title, Knee Injuries in the Physically Active, a Disaster Waiting to Happen.
Hi, I'm Dr. Lee Herrington. I'm going to do a short presentation with the title, Knee Injuries in the Physical Active, a Disaster Waiting to Happen, which is a way of sort of introducing a lot of the work we're doing within the theme of knee injury, biomechanics, and the understanding and management of knee injuries generally. So if we start to look at the extent of the problem is essentially based around, in these young physically active individuals, the risk of osteoarthritis and the risk of re-injury. And if we look at this figure, what we can see is if you have no knee injury, then your rates of OA are relatively low. But if you have any sort of knee injury at all, your rate of injury to the knee is considerably increased. And this is especially true if you disrupt your anterior cruciate ligament and then either go on to have conservative, non-operative management, or even to have an operative management. The rates of OA are very, very similar regardless of approach used. So if we look specifically at why we might be interested in an ACL population, well, there are two reasons. One is these ACL injury incidents are high relative to exposure, and they are particularly high in females. So again, we have a considerable gender mismatch, which we've considered in some of our investigations. The injuries lead to a considerable number of surgeries. So there are somewhere in the region of 6,500 ACL surgeries done per year in the NHS. And then conservatively, we can say there'll be at least 50% again, the number done within private practice. So we're looking at somewhere in excess of 10,000 ACL surgeries per year. So it's not an inconsiderable cost to the health service and to private medical insurance. So it's probably worth considering how we might prevent these problems. And if we look at lifetime risks again, OA is around 34% in this ACL reconstructed group, whereas it's only around 14% in the non-injured, which equates to a lifetime risk of total knee replacement of somewhere in the region of 22%, which is considerably more elevated than the rate of around 6% in non-knee injured individuals. Alongside the osteoarthritis, what we also have is a problem with re-injury. In the young, and this is in the under 24-year-olds, the re-injury rate of either the ACL graft, so re-rupturing of the graft, or damage to the contralateral knee runs at around 24 to 29%. And some more recent papers have actually said that number could be elevated to into the early 30%, which is considerable when you realise that most of these re-injuries occur within 2 years of the original injury and surgery. And globally, there is a relatively high incidence of re-injury within all age groups, not just this particular young age group. And the surgery itself and the risk of re-injury then equates to changes in physical activity. And what we can see is that these individuals considerably reduce their individuals. So if you look at moderate to vigorous activity, regarded as the number of steps per day, we can see that a large proportion of ACL reconstructed individuals either perform less than 40 minutes of moderate to high intensity activity per week, or they're way under what we regard as a typical 10,000 steps per day. In terms of their return to sport, it has been reported that less than 50% return to their pre-injury level of sport in this non-elite group. And when we go into this in more detail, what we actually find is 40% of people, which equates with the figure above, return to the same sport, 28% return to a lower level, and 32% do not return to sport at all. So again, that very much reflects that decrease in activity. which obviously not only has consequences for knee comorbidities, but also for general health comorbidities in this group. And what we start preliminary research is starting to show there are health implications as well as local knee issues which can predominate in this population. So it becomes probably important to start to understand the issues. And one of the things we know biomechanically in these individuals is they move differently. They will walk, run and land with decreased knee flexion angles and internal knee extensor moments in an attempt probably to decrease the load going through the knee. This obviously has consequences, and one of those consequences, slightly counterintuitively, is this will actually increase the stress on the patellofemoral joint and increase their predisposition towards getting degenerate changes. So what have we tried to do? Well, we've done a reasonable amount of work to try and understand the problem. Now, underpinning these papers I'll talk about in a moment is a lot of fundamental work which we've done on asymptomatic individuals to understand what is typical and normal before we've then moved into these pathological populations or in these prospective studies to look at what could start to predict injury. So we've looked at how pain influences the way people move in the patellofemoral joint, and also how that influences contraction of the quadriceps, which again are going to be very critical to the loading going through the knee joint. We've looked at the way these individuals move in terms of the load going through their patellofemoral joint post-surgery, and also the function of the quadriceps muscle post-surgery. We've also looked in a predictive, prospective and retrospective way to see if there's certain gait patterns which are associated with running-based injuries, specifically at the knee, but amongst others. And we've also tried to tease out the consequence of having ACL treatment, both in terms of movement, but also in terms of neuromuscular, so the strength, as we've already talked about, but also things like joint position sense and awareness. And then we've also looked at a more multidimensional understanding of why these injuries could be occurring, because it is highly unlikely these injuries will be just based around biomechanics, and they are often a multimodal perfect storm which occurs where both the athletes are weak, they have poor movement patterns, but also there is a lot of what we are calling cognitive overload occurring at the time, and this very much drives some of our solution focus, as we'll talk about now. So in terms of our solutions, we've looked at exercise from a conventional point of view, where we've looked at strengthening exercises and their impact both on pathology and pain, but also on movement. We've done that in specific populations, and we've tried to incorporate almost task or sport specific exercises in some of these events. And what we've moved on to more and more with our exercise-based research is starting to integrate a more skill-based approach, where what we've found is if we integrate some of the principles of movement skill learning into our approaches, we get superior outcomes which are more long lasting and require less intervention to achieve. So again, this becomes quite important as we move forward with these groups. The use of probably more what would be regarded as psychological motor skill learning approaches seems to be better, and also this allows us then to move into to start to address some of this cognitive overload we saw as one of the predisposing factors to injury. Because if we start to look at skill learning, we are likely to drive these behaviours to the more basic areas of our motor skill areas, so our cerebellum, etc., and leave our sensory motor cortex free for decision making. And so what we're doing is that then can deal with context as opposed to having to deal with basic tasks such as landing and change of direction. And these approaches seem to be superior for that. We've looked at a few other things to bring about acute changes in pain as well, because again, what we found is if we can bring about acute changes in pain, whether that's through taping around the patella or around bracing of the whole limb, what we can do is we can start to influence the way people move, but also influence the activation of the muscles, which obviously is going to make any exercise intervention more efficient and effective if we start to ameliorate some of the underlying problems. So we've looked at treatment adjuncts as well. And then as we look forward to the future, we have a few themes of work which are quite important along these lines. The first is we are very much driving an international consensus about what ACL rehabilitation should look like. From our work, which should be published soon, we know that current practices around ACL rehabilitation are all over the place and are massively inconsistent regardless of the type of surgery. There's a great deal of inconsistency, especially around the areas of early management to get reactivation of muscles and movement patterns, and also the decision making around when the individual is ready to return to high level activities which could potentially re-injure and stress the structures. A second area we're looking at very much is identifying key factors in injury predisposition. So we've worked with the Saudi military on a couple of projects to look at predisposing factors in recruits to see if we can identify certain factors which might predispose them. And again, working with the military is handy and ideal because it gives us quite strong internal validity to the studies, while still giving us a real world application of a real world training exposure or load exposure. We're also looking at other key factors around strength and also development. So we're looking both in terms of growth maturation and its influence on movement performance, but also on things we're calling survivorship. So in elite sporting academies, what sort of factors keep the people in the program, and the spin-off from that will obviously be injury. So if these people are likely to become injured, they're likely to leave the program. But if we can understand the predispositions, we can keep these people in these high-level elite programs for longer. So we have work around injury predisposition. We're also doing a considerable amount of work modelling biomechanically certain tasks. Rehabilitation exercises, as we've talked about above, are used in a fairly inconsistent way. So what we're trying to do is identify fairly clear biomechanical paradigms along which individuals can be progressed in order to expose, whether that's the knee, the ankle or the hip, to progressive increases in internal moments. So in other words, drive the adaptation through biomechanical modelling. And if we are going to model the exercises, we probably need to understand how the joint itself is being stressed by the interventions. So one of the novel tools we're looking at is thermal imagery to see how the knee is reacting to loading. And again, the knee is a very good candidate for this because it is a relatively superficial joint there, and here the theory being if there is any reaction of the joint, it is likely to show itself in synovitis and swelling, which will generate a superficial thermal response which we should be able to detect with imagery. So what we should be able to see is potentially early signs of the knee becoming stressed, and then obviously activities can be modified accordingly to manage those stresses. Thank you for listening. Hopefully you found this interesting. If you require any further information or have got any questions, my email is there, and by all means send me an email.
Great, so thank you very much indeed to Lee for that.